Okay, so our case was number 34, and our patient is a 16-year-old boy who is presenting with jaundice, and myself, Hilda, and Ken will be walking you through our case.
Okay, so we have a 16-year-old boy, and the chief complaint on admission was the presence of jaundice, and he also presented with irregular liver function test results. And on admission, or 4 days prior to admission, he noted pruritus around his ankles. He had malaise and mild intermediate cramping in his right upper quadrant. While 3 days prior to admission, there was fatigue and also reduced appetite with continued pruritus, which became diffuse. 2 days prior to admission, the patient noted that food had begun to taste funny, and also the fatigue increased, and there was also continued malaise. And the patient noted a change in the color of his urine, which turned black. While a day prior to admission, the patient noted the yellow discoloration of his skin when he went to school, and his teachers or the nurse at his school noted there was yellow discoloration of his skin, and that prompted him to come into the emergency department of the hospital. And on day of admission, he noted there was gray stool and then continued pruritus in the upper back. And when asked the intensity of the pain, he gave it a 6 out of 10, but there were no signs of lymphadenopathy. And on listening to his past medical history, everything seemed fine apart from the tonsillectomy he had in the past. There was no history of blood transfusion, and immunizations were up to date, so everything seemed fine with the patient. There was no clinically significant disorder, or yeah.
Did you need to go back, Hilda?
Okay, no. And with the family history, his mother had hepatitis in the past, although it was not resolved, and so they didn't give a name for it. They didn't identify what type of hepatitis she had. His grandfather had non-alcoholic fatty liver and also brain cancer, and his maternal second cousin had SLE. And social history, he was a high school student. He lived with his parents and 2 dogs. There was no history of recent travel or exposure to any sick persons, and he wasn't on any drugs, and he wasn't sexually active. And on physical examination, his weight was about 76.5 kilograms. He appeared jaundice, but he didn't appear to be ill. And his temperature was 36.8. His blood pressure was 135/59. His air saturation and ambient air was okay. His pulse was okay, and his respiratory rate was okay with 20 breaths per minute. And in palpation, he had mild right upper quadrant tenderness, and hepatomegaly and splenomegaly was limited because the patient said, or the patient was ticklish. So, yeah.
Okay.
Here, Samantha just going to go through this.
Okay. So further studies were done. So initially the red cell indexes, the activated thromboplastin time, anion gap, and the blood levels of electrolytes, glucose, amylase, lipase, and acetaminophen were all normal. Renal function testing was also normal. Blood analysis was done for the presence of heterophile antibodies, hepatitis A, AGM antibodies, hepatitis B surface antigen and core IgM antibodies, hepatitis C antibodies, HIV-1 virus, EBV virus, and CMV virus, for Borrelia burgdorferi, anti-nuclear, anti-mitochondrial, anti-smooth muscle, and anti-kidney microsomal type 1 antibodies, which were all negative. That's why there's the X's. And on urine analysis, the urine appeared clear, amber, with 1+ bilirubin and 1+ urobilinogen and trace amounts of albumin. The urine specific gravity was tested twice, with the first reading being 1.010 and the second being 1.018. The pH of dipstick was also done twice, and on the first time it was 5.5 and the second it was 6. And these are just some additional tests that were run. We mentioned the most important from this table, but if you wish to go back to it after our discussion, we can. A abdominal ultrasound was done on the patient, which showed mild, diffuse, heterogeneous ecotexture of the liver, an enlarged spleen, which measured 6.2 centimeters in length in the craniocaudal dimension. There was no intrahepatic or extrahepatic biliary ductal dilation. The gallbladder was contracted with no pericholecystic fluid, no ascites or focal splenic lesions were noticed, and the abdominal vasculature appeared normal. So bone marrow biopsy and aspiration were also done. So in panel A, we have a right James's stain of the peripheral blood smear. And panel B is a hematoxylin and eosin stained core biopsy from the bone marrow. And panel C is a right James's stain of the bone marrow aspirate. In panel A, there's evidence of pancytopenia with a small population of enlarged cells with irregular nuclei, dyschromatin, and scant cytoplasm. And these morphologic findings are consistent with the presence of blasts. On hematoxylin and eosin, which again is panel B, this the bone marrow is hypercellular for the patient's age, and a near absence of normal hematopoietic precursors is seen as well. And then in panel C, most of the cells are medium in size with round to irregular nuclei, dispersed chromatin, scant cytoplasm, and small nucleoli, which are again findings that are consistent with the presence of blasts. So to corroborate what we saw on our bone marrow biopsy, flow cytometry analysis was done on the bone marrow aspirate, and the abnormal blast population can be seen in gold in panels A, B, and C, and in blue on panels D, E, and F. In panel A, the blasts have greater forward scatter than the normal small lymphocytes, which are shown in pink. A finding that is indicative of their larger size relative to normal lymphocytes. The blast showed dim expression of CD45, which can be seen in panel B. The B cell markers, they're all positive. The cells were positive for B cell markers, which are CD19 and CD20, which is seen in panel C. They are also positive for CD10. In panel D, you can see that. And they're positive for markers of immaturity, which is the terminal deoxynucleotide transferase, or TDT, seen here in panel E, and for CD4 in panel 34. It's not shown here, but the cells were also negative for surface kappa and lambda immunoglobulin light chains. Fluorescence in situ hybridization was also done, which confirmed the loss of chromosome short arm of chromosome 9 in 92% of interphase nuclei. Now, this finding is considered a high-risk clinical feature in childhood if the child is eventually diagnosed with acute lymphoblastic leukemia. Multiplex reverse transcriptase polymerase chain reaction was also completed on the bone marrow aspirate. This did not detect fusions involving the ABL1 gene or other kinase genes. And I think, so with the patient's lack of medical history and the presenting symptoms of acute hepatitis, hyperbilirubinemia, leukopenia, lymphopenia, and thrombocytopenia, combined with the family history and physical exam findings and all of the laboratory test results, can inform us on the differential diagnosis for this patient, which included toxin-mediated disease, so things like acetaminophen overconsumption, or I think that was the only one considered, an inherited disease because of the family history with both grandparent and the mother having liver problems, infection, autoimmune hepatitis, or cancer. So the patient was okay. Thanks, Ken.
I'll take over from here. All right. The fluorescent in situ hybridization confirmed the loss of chromosome 9p in 92% of interphase nuclei, and RT-PCR results similar to the B-cell acute lymphoblastic leukemia with BCR-ABL1 rearrangement. So this patient most likely have a very high risk of B-cell acute lymphoblastic leukemia. Can you move to the next page? Okay, so for the treatment, the induction chemotherapy was done for this patient. In the management of this patient illness, the induction chemotherapy is done, and the national standard for care includes 4 drugs, which is prednisone, vincristine, and diaunorubicin, and polyethylene glycol asparaginase. But in this patient has a presence of hepatitis and clinical significant cholestasis, limits the use of some of this medication. Both vincristine and diaunorubicin are excreted through the biliary tract. So we did the measurement of direct bilirubin, and agent should be reduced when the direct bilirubin level is elevated. And it is omitted. Diaunorubicin is omitted with direct bilirubin is higher than 5.0 milligram per deciliter, and vincristine is omitted when direct bilirubin is greater than 6 milligram per deciliter. And for the polyethylene glycol asparaginase, it can cause clinical significant hepatotoxic effects, so it should not be used in this patient for now. Could you move to the next slide? So patient was diagnosed with B-cell ALL, and his direct bilirubin level was higher than 7.0. That's why 2 drugs were not used. And the treatment initiated other than 3 drugs. It started with prednisone only alone, and we monitored the daily liver function test for treatment guidance, and introduction of chemotherapy with increased liver function. So we use these drugs when we keep check the liver function of the patient, and after that we use these drugs later on. And for the case treatment decision, it was initiated with prednisone alone, and vincristine was started at 25% of the standard dose 5 days later, because when you use full amount of dose, it could cause the harm to the patient. And diaunorubicin was administered at 25% of the standard dose at the next day with the same reason. And full dose of polyethylene glycol asparaginase was administered on hospital day 11. And this was only used because when the direct bilirubin level had declined to 4.3 milligram per deciliter. And on the day 13, patient was discharged and induction chemotherapy was continued on an outpatient basis. Post-induction treatment was based on the modified Berlin-Frankfurt Münster chemotherapy regimen. It is 4 cycles of high-dose methotrexate delivered during first interim maintenance phase, and escalating doses of methotrexate delivered during the second interim maintenance phase. This is the timeline of clinical courses. If you guys can see on the x-axis, it shows the number is the day of the patient. Number 1 is when the patient admission to the hospital, and day 4 we diagnosis the and prednisone started, and on number 9, day 9, we started of induction chemotherapy. And this is because the reason why number 9 it called start of induction is because after we only use the prednisone at the start, but on number 9 we started the other drugs too. That's why it is actually called start of induction chemotherapy on number 9, on day 9. And on day 13, patient was discharged from the hospital, but the induction chemotherapy was continued. And on the day 37, the induction chemotherapy was completed. And could you move to the next one, please? Oh, on the day 8 of induction, the peripheral blood was tested for residual leukemia, and it showed 0.7 lymphoid blast. And test was repeated on day 12 of induction, and the level had decreased to below 0.01%. And on the day 12 of induction, test was repeated and the level has decreased to even below to 0.01. And on the final day of the induction, the direct bilirubin level has decreased to 1.1 milligram per deciliter, and bone marrow aspiration revealed complete morphology remission, and no detectable evidence of leukemia on flow cytometry with minimal residual disease. So patient experiences no major untoward complications associated with treatment and completed treatment at 39 months after diagnosis. And currently, 3 years and 10 months after diagnosis, he is well and in complete remission. Okay.
Any questions?
So, questions on the chatboard, I guess.
Thank you very much. Excellent. I have 2 questions so far submitted. Well, hopefully other groups will also submit questions. If not, well, those groups will just lose points for their final score. But just again, you guys still have time to ask the questions. 6 minutes we have. So question number 1, if you go to the chat box, it's from Florence Reynolds group. I think it's group 5. So it says, what is the mechanism of action of vincristine as a part of a treatment regimen? So who would like to answer from your group? Feel free.
I can answer.
Sure.
Please go on.
So vincristine acts as an antimicrotubular agent, and so like during the process of cell division, it inhibits the microtubules structures in the cells, and it prevents replication in cancer cells, and so ultimately results in cell death. And that's why it should be used in treatment of chemotherapy. Yeah, my bad.
Excellent. Thank you very much. Question number 2 coming from Takumi Kitamoto group. I think it's group 2. So why bilirubin level up and down until 14 days in this patient, I think. So this is the question.
The bilirubin level wasn't up and down.
Yeah, it was just keep going down.
Yeah, we needed the bilirubin direct level to reduce so as to increase the dosage of vincristine and doxorubicin, just so like there wouldn't be any like increased side effects of both drugs. That's why we were watching, or the physicians were watching to get it down.
Yeah, patient was closely monitored to see if he is able to use these drugs as addition of induction chemotherapy.
But the fluctuation in the bilirubin levels were because they decided to start him on indomethacin alone, which is an immunosuppressant. And so that
indomethacin is non-steroidal anti-inflammatory medication, actually.
Yeah.
Not immunosuppressant. Just clarify. Go on.
And so that, and they monitored the bilirubin levels until they were acceptable to initiate the induction chemotherapy.
Oh, but if to be more specific, going back to Takumi Kitamoto question, why bilirubin level was up actually in this patient from beginning of condition? So what caused his hyperbilirubinemia? What was the reason?
Anyone else?
So as far as I understand, he was admitted with jaundice, right?
Yeah, so he had too much bilirubin, right? So I think either his red blood cells were being destroyed too quickly, he had too many of them, and he had increased levels of bilirubin in his blood, and therefore that is jaundice.
So there are 3 types of hyperbilirubinemia or jaundice exist: prehepatic, intrahepatic, posthepatic. So to which type of hyperbilirubinemia or jaundice you would place this boy? Prehepatic, intra, or posthepatic?
Prehepatic?
Prehepatic, absolutely right. And why do you think he developed hemolytic anemia in this case?
Because he had abnormal cells within the blood that were being destroyed.
And why they were destroyed?
by the spleen because they were recognized as abnormal, so the spleen was getting rid of them.
So it was kind of autoimmune phenomenon.
Great.
Oh, okay. Thank you very much. Is it common to have jaundice in leukemias? As far as I understand, this patient had leukemia, right? B-cell leukemia.
Hilda, you got this?
So what you can tell me, guys, what do you think? Is it common for patients with leukemia to have jaundice? Probably a tricky question, but you can Google it, right?
It didn't seem too common.
All right. So, but in this patient, it was present.
Yes.
And what kind of jaundice or hyperbilirubinemia was in this patient? Was it unconjugated or conjugated or mixture of both? So which type of bilirubin was dominating in the blood of this patient, conjugated or unconjugated?
Conjugated.
Can you repeat?
Conjugated.
Conjugated. So is it classical for prehepatic or some kind of types of or autoimmune hemolytic anemias or hemolytic anemias to have conjugated hyperbilirubinemia, or it's something strange actually in this case?
I think they would be strange.
Why?
Because if the bilirubin is conjugated, that means that it is going through the metabolism in the liver.
Right. So that's why I'm kind of a little bit confused. So why this patient has conjugated hyperbilirubinemia, right? So when you're saying it was hemolytic anemia, which caused increased destruction of red blood cells, which caused actually hyperbilirubinemia in jaundice. So how to resolve this kind of phenomenon?
So I think that the bilirubin was being released from, or the conjugated bilirubin came from the liver, and I believe that the liver cells were being damaged from inflammatory.
Yeah, that's very good, very good, very good. And what do you think is what kind of markers will be elevated in the blood of a person who has damaged liver? So what besides conjugated bilirubin, what else you will see in the blood of a patient with damaged hepatocytes?
Transaminases.
Right. So what was level of transaminases in this patient?
They were very, very elevated. His AST and ALT were above 1,000.
So usually to have such high level of transaminases marker of what kind of condition?
Liver. Or
liver, you mean what liver? Cancer? Hepatitis? Alpha cirrhosis? So liver, it's kind of strange, right? So what liver? Add one more word to word liver. So so in what condition we see elevated level of ALT and AST? Most commonly.
hepatitis.
Exactly, absolutely right. So does this patient have signs of hepatitis? Of course. Look at this ALT-AST. So that's a sign. So, and why he has hepatitis? Is there any discussion on this?
It didn't. I don't believe the case went in too much about his
Liver condition.
Liver condition. No. It went more just into the differential diagnosis, and like I mentioned, they kind of went through all possible liver pathologies that correlated with his testing to either rule in or rule out those types of things. So, like you mentioned, hepatitis and acetaminophen overdose or infection was all ruled out.
Very good, very good. So, and in such case, my last question to you guys, it's why do you think he has liver damage, this patient? What caused liver damage in this patient? How in this paper, in this kind of case, would doctors explain liver findings in this patient?
I would say it didn't go into the specifics, but my best guess would just be just inflammatory infiltrates damaging the cell.
Infiltrates by what?
Sorry?
Inflammatory infiltrates by infiltration by inflammatory cells, right?
Yes, yes.
So you're saying this patient has some kind of hepatitis, right? That is what the additional diagnosis.
Yes, I guess.
Gotcha. All right, guys. No, thank you very much.